thank you everybody for coming in person and for those on Zoom and for tolerating our starting a few minutes late. There were elevator issues at IHPS, and so we know some people got hung up in the elevator or trying to get the elevators, and then it's right after lunch or kind of during lunch. So it's the usual thing. We are really happy today. Oh, Beth is telling me to move over. We are very pleased today to have Kate Rendell here, who is from Penn. And she is an assistant professor of family medicine and community health, and also epidemiology, has joint appointments, but family medicine is the primary home. LDI is a collaborating institute home for her. And she is the associate director of the Penn Implementation Science Center and associate director of the Mixed Methods Research Lab and a member of the Cancer Center at Penn. So she is going to tell us about her research related to advancing equity in cancer care. And so I'm glad you made the trip out for the special seminar. Thank you.
Absolutely. Thank you for having me. Beth, you'll let me know if there's any sound issues online. I usually am not a quiet person, so that's not usually an issue, but thank you all for coming. Thank you for having me. My name is Kate Rendell. You can call me Kate, is fine. And today I'm going to talk about different ways in which I think about how we can advance equity across the cancer care continuum. This is from screening all the way through treatment. And I think about it in ways from not only implementation and design, but actually the evidence that's built, of course, on evidence-based practice. Who's included? What does it mean? And how can we increase equity there as well? So I'm going to start with a little bit of my research framework, a little bit of the cancer screening landscape, and then I'll talk through a couple projects, 3 of which are recently funded, and then one that's sort of in the tail end, the U54, that's sort of an outcomes, but I've used it to sort of think about advancing pragmatic trials in the others, and then hopefully have time for questions and discussion. So I like to start where I started, which is at a traditional medical anthropologist. And I sort of think about the ways in which I both develop and think through context in my research and my approach. So anthropology, of course, traditionally takes a very holistic approach to studying any phenomenon of interest. So while you might have one question that you're looking at, you really think about the ways in which many different domains come to bear on this single question or phenomenon. After I got my training in anthropology, I wanted to think about, well, how can we think about what is the potential effect of one of these contextual factors on the phenomenon of interest while maintaining this holistic perspective. And so I got training in epidemiology, and in epidemiology, context is almost as the thing that gets in the way, or the thing you have to account for between an exposure and an outcome. So going from like, this is the thing to this is the thing that we have to account for so we can understand this relationship. More recently, I've sort of brought these together in implementation science. And in implementation science, context is a little bit of both. It is both the thing that gets in the way, but also the thing that enables or facilitates whatever you're trying to implement. And really, this is the consolidated framework for implementation research, is a well-known established framework. And you can see that context is really key. It's central to the framework. So across my work, I sort of use different components of this, but sort of bring in these sometimes isolating contexts, sometimes thinking about how it accounts for outcomes, but trying to maintain that holistic perspective in a balance to affect change. A lot of my work, I think about this in healthcare systems. This is a nice model, onion model, one way you can think about the ways different factors at different levels impact an outcome. So this sort of multi-level components. A lot of my work, I start with what is understanding the context. I use that both EHR data, sort of large-scale observational analysis, complemented by mixed methods research to understand not only what are the gaps, in particular with equity, but also what are the potential drivers or determinants. But of course, healthcare and everything else in life is not a nice little model. It's actually quite complex. And so more recently, I'm sort of thinking how these different factors dynamically can configure what it means to have a health system. And this is not just in the traditional health system in the organization, but the actual cultural context by which we define health and improve care. Increasingly, I try to think about in pragmatic and implementation trials, how can we pull different levers at different stages to improve outcomes and equity. So in the context of healthcare delivery in the United States, there's been sort of a historical divide that I think is decreasing, but is still largely there between healthcare delivery and public health. public health thinking about the population and how you can impact care, outcomes at that level. Healthcare delivery, largely just because you're in the clinic with a patient in front of you, thinking about the individual. Increasingly, they are integrated both from a practice perspective, but also research perspective, and thinking about how you can think about the population, improve the population, while also serving the needs of an individual patient. At the same time, within this sort of transitions, there's a bit of a tension between a more targeted approach, you can even say, the individualized approach and this more precision medicine approach, and a more blunt approach to population health, where you might be looking at averages and how you can sort of impact that at that level. So while both are important, there's a tension and an opportunity between thinking through these two approaches. In cancer screening, the same is playing out, where historically population level cancer screening really was a large blunt instrument, where there may be one or two factors, age, sex, where you sort of identify who's eligible for cancer screening, and then you have one cancer screening strategy. Increasingly, we're thinking about risk-based approaches, and this sort of underlying idea that there should be equal management, equal screening strategies for equal risk. And so you might have an individual level assessment of cancer risk, and then different strategies, cancer screening strategies, based on that risk. And these could differ by modality, by frequency, start, stop age, and a variety of other factors. So there's a lot of opportunity and benefit for risk-based screening. You can argue that this really identifies those people most likely to benefit overall from cancer screening, but there's also considerations of equity. Three things that are buckets I think about this, there's probably more. When you think about how do you implement risk-based screening or risk-based approaches, and how do you make sure that they actually can be equitable? And of course, at this sort of core, if they are more complex to implement in settings that have less resources, less knowledge, or just any setting, it's going to be more complicated. And if these delivery systems are those who potentially care for more underserved populations, then inequities could increase. The other is in data capture. So let's say you actually implement this strategy within a system or a community or a place. A lot of these actually require additional data, additional risk factors to be collected. We know that access and engagement with healthcare systems, with community settings, is a driver of whether or not you have this capture of data. So again, if you have underserved communities that have lower data capture to identify those who are eligible for risk-based screening, inequities could increase. And last, but certainly not least, the very data and evidence that goes into guidelines, if it is not representative of communities across the United States and globally, that the risk-based models, the guidelines are based on, and you see differential benefits or just lack of representative to even know if there's differential benefits, then inequities could increase. I like to think about that all of these are the results of action. Inequity, including, is not just by happenstance, it's by the system that was defined. So if we think about these things and prioritize, actually the opposite might be true, and implementation of risk-based approaches might decrease inequities. All right, so that's sort of overall. Now I'm going to jump into several projects, starting with cervical cancer screening. Cervical cancer screening started as a very blunt instrument. But even though it was a blunt instrument, it actually has been quite effective. And so this is sort of a graph that you see the decrease, over 50% reduction in cervical cancer mortality since the implementation of population-based approaches. Now you'll see that over 4,000 females are still going to die from a probably entirely preventable cancer. And so that should not be ignored. But when you think about the global context, where there's over 300,000 deaths each year, it's actually, become a rare cancer. However, it's not equally beneficial. You see that there's still disparities by race, ethnicity, and other factors. Now, this change didn't happen overnight. It also didn't happen as the result of one thing. So you can sort of see on the bottom in the light bluish, purplish boxes that there were actually changes in the technology by which we detect, and we got better at early detection with cervical cancer and knowing sort of what was going to happen next. The guidelines that classified results from testing, primary prevention with HPV vaccination. But over this time, as a result of these changes, guidelines changed drastically, starting with annual screening. If you started screening in the 70s, if you were a female, all the way towards more primary HPV extended frequency screening at a lower frequency. So underlying this was 2012. There was consensus guidelines that said that no woman who is eligible, no female that's eligible for routine screening, so this is average risk, should be screened every year. And under this guidance, again, is this equal management for equal risk. Along with these guidelines, there was also the introduction of primary HPV testing, human papillomavirus testing, actually starting in 2015. But in 2020, the American Cancer Society actually said that this test is the best test and should be the preferred strategy. It hasn't really been taken up, but there's also been questions about even these extended guidelines. So when I was a postdoc at the NCI, there was an opportunity, the Kaiser Permanente Northern California, KPNC, guidelines cohort that really was the cohort by which some of these guidelines in 2012 were built upon. I wanted to take this cohort and say, in a very organized health system, what does it look like over time, uptake of these extended guidelines? KPNC implemented triennial extended interval screening earlier than the 2012. So this is the longitudinal assessment. Basically, the years on the bottom are the year in which the females were first screened. And then I did longitudinal assessment to see what did it look like when they came back? How long were these intervals? And by the latest cohort, you were seeing about 60%, a little over 60% of females that were screened according to guidelines. Still, though, about 16% were screening too frequently. And those who were screening late were sort of hovering around where they were from the beginning. Now, sometimes, I do work in both increasing cancer screening and cancer treatment. And people ask me, well, why do you think about overuse, or why think about why people are screening more often? And for different variety of cancer screening, there are different levels of harms. But for cervical cancer, the harms of overuse can start with overscreening. Getting a PAP is not an enjoyable experience, or a co-test. And so, that in itself, if you're screening more often than you should, but the bigger sort of downstream impact is that when you screen more frequently, you tend to pick up transient HPV infections. And so that will lead to false positives. And then if you have a positive test, you have surveillance that can lead to diagnostic procedures. And so that's really why this is important. The length of time that you get an HPV test is really important, because otherwise you'll pick up these viruses that would clear for themselves and wouldn't need any treatment. And cancer screening is always about the benefit of risk and harm. And so it's not, these are healthy people. And so you want to think about what are those potential risks in addition to benefits. But I also think about it at a system level, particularly sort of there's, psychosocial harms, physical, financial costs, but opportunity costs at a system level, particularly coming out of the pandemic where there's long wait times for screening. If you're taking appointments and screening people that maybe don't need it, that is an opportunity cost to focus on those people, those 4,000 people that are still dying from cervical cancer, and getting them into timely screening. So jumping into a project, when I came to Penn, I thought, well, Penn is a mix of academic and community clinics. It's also not an organized system like Kaiser. So I wanted to know, well, what does it look like here? What are the trends in overscreening using EHR data? And then what are the drivers using a mixed methods approach with patients and providers? What did I find? The figure on the left, you'll see that this is, again, sort of anchored on people that are coming back for screening, their intervals. And over time, from 2018 to 2020, it's sort of, around 60. But what I thought was most remarkable in the pandemic, it actually increased the proportion of women that were screening too frequently out of all those who had been screened, sort of reflecting that these women may be really habitualized into females, maybe really sort of routinely coming back. And so about 60%, so again, this is almost closely exactly to the number of adherent rates in Kaiser. This is the proportion of females that were being screened too frequently at Penn. People that were being screened by gynecologists and that were non-Hispanic white females were more likely than those in other primary care and non-Hispanic Black females. So when we talk to patients themselves, surprising, and again, 2012, no guidelines said that you should screen every year. 70% of these patients thought that they should be screened every year. And the drivers weren't surprising. And the bottom quote is really sort of driven by the trust and judgment of their doctor. If their doctor is saying they need to be screened, they're going to be screened. But also that this 69-year-old female was saying, I've been screened for a long time. I've seen a lot of changes in guidelines. So why am I to trust that this new guideline is something that I should follow? So reflective again, back to that timeline and how much has changed in 40 plus years. When we talked to physicians, similar, some similar thoughts sort of came up. But what was remarkable to us is that, this provider really sort of highlighted that, there are few providers that don't know the guidelines or that they don't want to memorize them. But it's actually in that communication and discussion that sometimes it's just easier to do the PAP than to talk through why it's changed, what the guidelines are, and why you should not be screened at that time. So we thought, sort of what could we think through potentially to prime this conversation? And this was supported further by this patient who had said to us that they had screened more frequently. That their provider actually did say that it was sort of up to them, but they did tell them that it wasn't recommended. This patient did say, I went ahead and went screened. But because of our interview, they actually did some reading before, and then they sort of reflected to us, now I think I'll actually follow the provider's recommendation because I had a little bit of time to digest. So we took this and developed it into an R01 that just started in August. We're working through how to operationalize this, but sort of using a frame, of course, of behavioral economics and nudge strategies. How can we use different strategies to make it easier to follow guidelines and harder to not follow guidelines? We did a little bit of testing with the patient messaging because we thought, well, what if the patient sort of outreach is enough? And this was a experimental design using frame messaging, which is just a theoretically informed development of communication that basically says how you frame messaging, whether you emphasize positives or negatives of the behavior, changes how people respond. And actually, we saw no framing effects because largely they were both very effective. But the sort of decreased intentions was only 10 to 20%. So we thought that this is probably necessary, but not sufficient in itself. This is the theoretical model that's driving the R01 in addition to the aims. And so you'll see on the top is a pragmatic approach, factorial design, where we really are trying to test the patient, provider, and then the combination of the two to decrease rates of overscreening. This pragmatic approach is all EHR outcomes, and then it's coupled with mixed methods evaluation. You will see this approach in the next projects that I talk about. So shifting back to the global equity, so really thinking about cervical cancer, it's really hard if you were focused on equity to stay in the United States. Because as indicated by this map, you really see the vast majority of these deaths are occurring in other places in low and middle income countries, with a substantial amount occurring in sub-Saharan African countries. And in the country where I work, Botswana, the mortality rate is tenfold that of the United States. This is a combination of factors, including the prevalence of HIV in these countries. So in Botswana, people are screened all throughout the country. This was part of an interview where we mapped where people were coming from, where they got their screening done. It was often symptom-based, but there is only one place in the country where you can receive cancer treatment, and this is in the capital city of Gaborone. And so when we were thinking through a project, we wanted to, again, first contextually understand what the drivers were. And we found that actually the biggest drivers were sort of in between the time of diagnosis to treatment adoption. That was the greatest delays that we saw from a quantitative perspective. This is using a clinical cohort of patients. When we talked with patients, not surprising, the distance to get to the clinic was a barrier. But what we heard more often and more modifiable was really that they just never even knew that they had a positive diagnosis and that they needed to receive treatment. So that was causing the delays. So we have a new UO1 that's with partners in University of Botswana, in addition to my colleague, Dr. Grover, who's a radiation oncologist who lives and works in Botswana. And we leaned into the contextual restraints of Botswana to develop this trial. And so what we're doing, there's only 2 health laboratories in the country that evaluate all of the biopsy samples. So we're actually embedding our first intervention in the lab, and then the second intervention in the treatment clinic. This is using a SMART design, which is sequential multiple assignment randomized trial. You'll see this model again. I like it because you can sort of think about it that just like with medicine, not all people need the same level of dose. And so the same sort of approach with behavioral strategies, particularly when you think about sustainability, not everyone is going to need that high touch approach. Not systems can't implement at that high level, but we can sort of test it. What is the proportion and what does that look like when you sequentially offer people these options? So I'm going to jump to lung cancer screening. We're good on time. That started more as a risk-based approach than many other cancer screenings, but I think it's going to continue to move in that direction. So in contrast to cervical, this is the leading cause of US cancer deaths, with about 130 deaths estimated last year. And there are persistent disparities, particularly between non-Hispanic Black men and non-Hispanic white men. This is sort of the result of many disparities along the continuum. Luckily, we do have an effective screening strategy that was based first on the results of the National Lung Screening Trial that showed a 20% reduction, and then has subsequent other trials, the Nelson and the MILE trials, shown similar benefits with about a 16 to 20% reduction using low-dose CT. So this is the U54. So this is a outcomes-based research grant that we're in our 5th year, and really was designed to be a opportunity to bring together health EHR data from 5 different health systems to look at outcomes of lung cancer screening in community practice. We know that trial data and community practice are not often the same. The people who are in trials versus the people that are actually receiving care in community practice are quite distinct. But this was sort of the near to the beginning of when lung cancer screening was recommended. And this really has looked at outcomes across the continuum. We developed a screening process model to lay out these steps. So really stepping back and say, screening is really just the beginning. You need to have all these steps in place to be able to be a high quality or an effective screening program. And lung cancer screening is unique that it requires both risk assessment of age, but also smoking intensity. And that's the sort of movement towards risk, pack years, which is complex. And then it requires, CMS requires shared decision-making and smoking cessation counseling before an order. Of course, then whose order will have results. And if you have a negative result, you're supposed to be screened annually. Those who have cancer, a positive diagnosis, a positive screen, go on to abnormal follow-up and treatment. Of course, this is not even covering all the contextual reality. This is sort of just a map of how it was working when we started at Penn. But there's a lot of different steps that have to come into to even achieve that first step, let alone after. So these are the guidelines, and this it's 2013 was the first time that it was recommended. And age 55 to 80, 30 pack years or greater, and that's the number so average number of cigarettes that you smoked and the number of years that you smoked that. And so you can sort of see how even that calculation is hard to describe to someone that thinks about this a lot. When you're a person, many people, of course, don't smoke 5 cigarettes every day for their entire smoking history, but they'll smoke more, they'll smoke less, they'll quit. And so it's a complex sort of cognitive burden for individuals to calculate, in addition to physicians and healthcare systems to identify. And then I mentioned the tobacco cessation and shared decision-making. In 2021, the USPSTF updated, United States Preventative Services Task Force, updated their guidelines, lowering the starting age to 50 and decreasing the pack years to 20. The reason that they did this was largely because there was evidence and concern that the guidelines themselves were not equitable. And this is partly driven by that there's evidence that by race, so African-American adults versus white adults, that actually the proportion of people who get cancer at lower pack years, that yellow line, is greater in African Americans. So when you have that 30 pack year, you're actually going to, at the start of the guidelines, have inequity built in. And so they thought if they changed it, there may be more equitable implementation. So our group, in addition to many others, said, okay, there's guidelines, but what does this look like in practice? And when we used our longitudinal cohort and the PROSPER cohort, we saw that yes, this will, not surprising, expand the number of people that are adults that are eligible for lung cancer screening by 54%. And yes, the increase in expansion will be greatest in our non-Hispanic Black adults, but you sort of see that it's also higher proportion in comparison to all other groups and then non-Hispanic white. However, eligibility or even cancers detected is not actually the marker of whether or not a screening program is successful. It's actually sort of in those life gains. If you detect cancers that aren't going to kill people, or and that don't result in life gains, then that doesn't necessarily mean that is an effective program. This is work that it's a complicated figures, but really just to highlight that in blue and green are the changes from 2000. Green is 2020 and blue is 2013. That top figure in A, you see that actually the disparity by race is largely the same between the two different guidelines. And only when you use a risk-based model do you get to actually a disparity that is 0 or 1 by race. And so there's sort of a debate on what it means in equity when the guidelines don't necessarily, expansion of guidelines might be one thing in eligibility, but it doesn't necessarily result in life gain. However, from an implementation perspective, we have guidelines right now, and there's still much work to be done to identifying and getting people in who are currently eligible. So this is just a depiction of where we start to lose people in our Prosper cohort across our 5 sites. And you can see sort of at that first stage of those pack years, as I noted, we have about 70% of missing adults in the age range that have no pack years. So we can't even identify whether or not they're eligible. And then depending on how you define your denominator, between only 4 to 22% are screened. And then of those people that are coming back, annual adherence, only 54% are coming back. And then actually we're doing better, but not great for abnormal follow-up. When we looked at decentralized versus centralized programs, so this is a sort of approach where you have a centralized nurse navigator that reaches out and tracks people versus a decentralized, largely primary care driven program. We found that in the decentralized approach, Black race was associated with a 27% reduced adherence. But when you looked at the centralized program, this effect by race was not observed. You can see in the boxes though, however, the crude difference between decentralized and centralized, 30 to 80% roughly, is substantial, sort of leaning into, and there's growing evidence that centralized approaches are more effective for lung cancer screening and probably other types. So now I'm going to shift. Oh, yeah. Yeah.
Can you just explain one more time what was the difference between a decentralized, what is a decentralized system versus a centralized system?
Yeah, so a decentralized, and there's large systems or hybrid systems, but a truly decentralized system would be completely sort of primary care based ordering, assessment, follow-up for people that were eligible for lung cancer screening or any types of cancer screening. A centralized approach would usually be something often outside of primary care. It's in radiology. It doesn't have to be, but there's a program that's sort of tasked with maintaining, identifying, following up on patients who have been screened, should be screened. And then the hybrids are usually something in between, somewhat of a hybrid where we have primary care can still order, can have, all sort of autonomy with regard to lung cancer screening, but we also have a centralized program with a nurse navigator and other factors.
And then just one other question, that figure of the Black male, white male, Black and white females highlighted that there seems to be a very clear gender difference. And so there's so much, you've done so much interesting thinking about context and all that. And I was just curious if you thought about the gender difference, yeah, and how that intersects with the race.
Yeah. And we are in one of the trials that I get to. So the evidence for the by sex and by race, that the guidelines were inequitable for females as well. So at the very core of the risk of lung cancer, those initial USPSTF guidelines, that there was, again, sort of higher rates of lung cancer at lower pack years. So different smoking behaviors, what you smoke, how often you smoke, and many other factors. And so both sex and race has sort of been highlighted as the purpose and reason why those guidelines were expanded. But I think it remains to be seen if it actually, because often females are the ones who are actually screened more than males when you're just sort of looking at any screening. But the benefit is where there's the inequity in the guidelines. So it's good. You teed me up. So back to the process model. So I have a variety of projects on the bottom. I'm not going to go through all of them. that really is trying to think holistically, back to sort of my approach, about this whole process while identifying different components where we can measure and impact change. One of them is we have a P50 that's co-led by myself, Justin Beckelman and Neil Pachani. Justin is a radiation oncologist and Neil is a pulmonologist. I work closely with both of them. But we really sort of brought together both clinical expertise, but also expertise in communication science, behavioral science, implementation science, and thought through how we can use lung cancer as an exemplar model to think about how we can implement telehealth more effectively and equitably. In the process of our application, I led a development of a framework that we use to sort of in our application, but are using it in all of our design and thinking and hoping to sort of this can be a model that people can use. And you can see again, the onion is still there where you see the multi-level societal outer and inner contexts, the intervention characteristics. But at the core of it, we have this patient and clinician encounter that is important and how those determinants can come to bear on the communication aspects. But more importantly, thought through complex sort of understanding of what the digital divide means and how it can be operationalized sort of to be focused on equity. So of course, access to these technologies is key, but also key is skills equity. So sort of designing for different levels from the beginning. And then also empowerment. So sort of the understanding that these technologies can help improve your health, trust, medical mistrust on the other side. Sort of thinking through at the core, how can we design a strategy that really targets all of this from the beginning? Our hope is that in the pragmatic trial, this will increase shared decision-making for lung cancer screening and also decrease inequities. I'm not going to talk about it, but we have a pilot project that's in molecular testing in lung cancer screening. So again, using that continuum to think about how we can improve care. The specific aims of the pragmatic trial, this is a patient level smart design again. I have an MO, and it's really about determining the effectiveness of these different strategies on the visits. And then of course, people that want to be screened, the completion of low-dose CT. We're also thinking through reach and access, timeliness of care, and implementation costs, because we know that that's important, particularly in screening. This is where, so back to the sort of why we chose race and sex is because the evidence is differential. This is a large trial, 9,000 patients. It's not driven, the power is not driven by AIM 1, it's driven by AIM 2. We wanted to make sure that we were powered to know we do not hypothesize that it will work better in either race or sex. This Black adults, white adults, those are the two groups we have most prevalent in our healthcare system. Female adults and male adults, those are the two groups of comparison. But we want to know if it doesn't work as well. So we're powered to use a non-inferiority testing to detect a very small margin of difference. And then, of course, guided by FIGHT, we're going to have a robust evaluation of the mechanisms, not only that lead to success, but lead to failure. Failure is just as important. Why didn't it work and how can we change? And then, of course, understanding why it did work. This is the overall design. I won't talk through too much, but it really is designed to think about not only, sort of at the stage 2, this is trying to help people get to that visit using digital care coordinators, addressing concerns, access skills, motivation to use telehealth. At the first, it's actually also thinking about preference for telehealth versus in-person, because that's another question sort of from a scalability. You can't offer real-time choice to all patients, but what happens if you offer one group only telehealth and one the opportunity to have in-person and telehealth? What proportion are actually going to choose that option? And then, of course, what does it look like for outcomes? So to wrap up, a lot of people increasingly, rightfully so, talk about how you design or implement for equity, design for equitable implementation, but sometimes it's sort of unclear what that means. And so, I'm not going to go through all of these, but we really have started to catalog and think through what this means in tangible action. And really, the important factor here is that it really does start before, and this is at the level of evidence. when you think about design and powering your studies. During, you can think about monitoring and adapting recruitment strategies if you see differential response, and then after, and really understanding if there were effects that were differential by key determinants of health, but also sort of the why and how of each of those. So looking ahead, we know that risk-based models, risk-based approaches, more targeted approaches do perform better in the classical sense that you're going to identify those people that are going to have a higher net benefit for screening and other components of care. But just to highlight sort of, again, the underlying data in our systems, again, 70% are missing even pack years. When you start thinking about some of these other risk factors, and different models have different risk factors, they're largely completely missing. And so these are in high resource. Again, also sort of the underlying evidence of some of these risk models are not representative of the United States. So to sort of end, at the end of my career, these boxes will be filled in. What they will be filled in, I think is still, I could hypothesize, but don't know. But in this, the change will come. But what's not inevitable is inequity. And inequity has always been the result of action. And so if we think about prioritizing inequity, planning for it, and concerted efforts, I think we can shift it and have that equity is also a result over these years. And with that, I will thank my probably many more collaborators and all of you. There we go. Yes, time for questions.
Microphones.
Yeah. For the Zoom folks.
Hi, great talk. I would go back to the cervical cancer screening that you talked about at the start. You motivated by saying that there's a number of harms of overscreening, including time, financial costs, unnecessary procedures. And I'm wondering how you sort of translate that into the messaging that you have tested in terms of especially you talk about frame messaging, do you pick like one of those or all of those, and sort of do some of those resonate more with the patients than others, and sort of how that gets integrated into your work?
Yeah, so great question and a tricky one, because we are taking a very conservative approach, meaning we want to use a pragmatic approach. We know one of the challenges with identifying with overuse, in addition to sort of deciding to choose to screen more frequently, is that screening history is not well identified. You have to search through some of the records to identify it in the EHR. So some of this really is like structural. You don't actually know someone's screening history. And then of course, people change health systems. Wouldn't it be nice if we had a national screening history registry? So we had developed messaging. The messaging that we had tested, back to your question, was much more neutral than persuasive. It had framing of the benefits of screening according to recommended guidelines. We'll detect cancer early, save your life. But we've now gotten feedback from our behavioral theoretical scientists that it needs to be more persuasive. And so we're testing right now, we're sort of developing, making it more like personalized and persuasive with regard to the specific overuse. We will probably avoid like specific, we had in there like can have, screening less frequently, will give you equal benefit and avoid potential harms. And so that's sort of at a more neutral perspective. But I anticipate when we have a wonderful clinical stakeholder board, I imagine that when we present both, they're going to have us move more towards that neutral. Because again, it's just sort of it's very important that we don't decrease screening in people that are due. But at the same time, you want it to be effective. So we haven't quite figured it out. We had a meeting last week to try to figure out the balance with what we're going to present. But because a really persuasive messaging, like the literature, you want to say like, you are not due for screening. No need, like make it personalized, make it directive, make it short. But I don't think that's going to fly here. So, yeah.
Great talk. Thank you. That point, wait for Beth to. Sorry. Sort of following up on a little bit about what Justin's question, so part of the issue with screening recommendations is that for each cancer, there's a different screening recommendation. And so you target overscreening in cervical cancer, but then, there's all these other cancers. And, with liquid biopsy coming to the forefront, I mean, how do you message so that you don't, walk that line where you encourage appropriate screening, but, with differing guidelines, is there a risk of unintended consequences where you are basically, having effects on other screening programs?
Yeah. So yes, people, communities, and primary care physicians, of course, don't like. Now I'm talking about cervical cancer. Now I'm talking about lung cancer. Of course, it's the holistic approach, and so I do think that when you're communicating, messaging cancer screening to individuals, you're going to have a little bit of the eligibility, but it's largely, sort of, again, this sort of more neutral. If you follow guidelines, the evidence is strong that the guidelines, I sort of undermine that statement by showing some of the inequities in the guidelines, but that following those guidelines, whatever they may be, is really important to communicate and make sure that people trust them, again, because that's the other, that's differential by different groups. It's also really hard if you've been screening for a long time and they change that much. So I think that, from the perspective of any of these approach, those patient level education is just the foundation. It really is, I think, in that trusted relationship between the physician, care provider, whatever it may be, and the patient. And so we're trying to prime that, reduce the time barrier to primary care physicians, hopefully help them have less of a time to communicate what that may be, a little bit with the patients to have questions. We have some embedded questions that we're sending out to patients that they can say, what is my recommended, what are the risks, what are the harms? But we don't anticipate that patient one alone will be enough. It really has to be that interaction between the two. But yeah, it's not easy.
Do you have an online question?
This is from Hannah Asman. Fascinating. In the under and over screening cervical cancer study, did you find any patterns of provider-patient dyads in the terms of provider giving advice to screen versus patient acceptance of screening, whether by race, age, or other variable?
Yeah. So we, in the qualitative, it was a smaller sample. We did do clustering, and this is some of the balance of working closely with clinicians. I could tell you there are physicians that overscreen more than other physicians. We don't report that, but there absolutely is a strong clustering effect by individual providers. For the qualitative, we didn't have the data from all of there's, many primary care docs that are in the, and nurses and practitioners who are in our cohort, and patients as well. So we haven't looked specifically at the dyad between the qualitative and the providers, and it would be a small sample and a very interesting question we can look at. But my guess is yes, there's absolutely, I think, the strongest driver in a lot of why you have to control for provider recommendation in any sort of study is that a lot of these patients really were deferring to their physicians. Some of the physicians said, oh no, my patients really want to be screened a lot more and I have to fight them on it. Our evidence didn't really find that. I think there's probably some, but I think they're, highly activated and probably not the majority.
Because we all love Pap smears.
Exactly.
Actually, though, the cervical cancer study, I thought was very interesting, and I think I have a broader question that's related to the whole de-implementation of, or reducing screening appropriately, is the financial piece of it.
Yeah.
If you are the normal private practice world and not Kaiser or the VA or integrated systems, it gets a patient in every year, you get your appointment every year, you get your billing every year, you get your whatever. Did physicians or the clinicians that you interviewed ever admit this or even express concern like, well, if I'm doing it every year, then I'm also giving them a breast exam that they need, or like what,
Yeah. So great question. And some of them did recognize. So there's a couple things. There's the financial reimbursement and study, patients coming in, but it's also that Medicare and Medicaid will allow for annual screening for risk-based variables that are not aligned with evidence. And so it's even at the payer system that they're not restricting based on guidelines whatsoever for a variety of reasons. But and I think that they recognize it, and it's partly we are not intervening on annual visits. So even the terminology, right? Annuals, right? That meant an annual PAP. I mean, the word itself is sort of to change to the guidelines. That's not actually evidence-based either, but we're not going to touch that in this study. We're going to allow people to come in because for some women, it really is their only source, females, it's only source of healthcare. They talk about all sorts of things. And someone told me, for people over 65 that have a normal screening, why are they still being screened? Some of it is, and very clinician very rightfully highlighted that it's an opportunity to have an exam. You could just do a pelvic exam. You don't have to do a scrape too, but in an exam for a body part that these patients aren't looking at. So they identify other things, right? But that trickles down into some of the patients when we talk to them. They didn't realize that a PAP only detects cervical cancer. They thought a PAP protected them from ovarian cancer, from all sorts of things. So I think we can do better. I understand the financial structures and I understand the policies. I understand that it's a really source of care for some patients, but I think from a system level, if you shift it to the people that were due for screening, then it might still be sustainable. So there's probably some cases where it won't, and it would be hard to do without it, but the evidence is very clear.
I have a second question. One of your slides that was on the racial differences with lung cancer screening, for people on the lower PACs, and yeah, I'd love to see that slide again.
Yeah, and
because it was
this isn't mine, but
there it is. The disparities, the racial disparities, especially as you get down to the fairly low end of that distribution, are remarkable.
Yeah.
And if I were just going to throw out a guess, it's probably environmental and the kinds of things that Tracy Woodruff does on pollution and so on.
Yep.
But yeah, I wonder, because I would imagine that those kinds of disparities exist if you had the never smoked population in here as well.
Right.
And then how does one tackle that?
Yeah. So great question. And there's also menthol cigarettes. There's differential by race, and so that is a big hypothesized driver. This isn't my research, but those are sort of the thoughts on it. In addition to air pollution, in addition to all the other drivers and access to care, all of the things that come to bear. We have a study I didn't talk about where we developed a video it's using an actor, but an imagery from South Philly because of the air pollution. And we're testing on whether or not that would increase people coming in for lung cancer screening if they knew the air pollution was also, it's not part of the guidelines. And so it's sort of tricky. You have to make sure they're still eligible for it to be covered. But yeah, I think that there are a lot, this is sort of catching one component of it by talking about PAC years, but there's a variety of other reasons why there is such a persistent disparity particularly between Black men and non-Hispanic white men.
Unidentified asbestos exposure, right? Old housing.
Yeah, particularly in West Philly. Yeah.
Thanks, Kate. Totally fascinating. Now we're on PAC years. I just wonder if you could clarify on a bunch of your slides. It has the sort of less than 70% PAC years thing.
Yeah.
Can you say again what that means? And then I have a totally unfair follow-up question.
Yeah. Excellent. I love unfair follow-up questions. When you take a population health approach for identifying the denominator of cancer screening, it's usually maybe their sex, but their age, right? And age is something that in EHRs are well captured, in community assessments are well captured. And so you can sort of say, well, this is the denominator of people that are eligible, and these are the number of people that are being screened as sort of a key step of the reach. For lung cancer, we can't even do that because we have in the EHR of patients that have information on age and sex and a variety of other factors. They're completely missing PAC years. So we don't know if they're eligible, and we take a conservative approach. We take a very restricted approach. It's a tenfold difference if you require PAC years for your denominator. So, saying whether or not you're reaching the right population, we're struggling with that. We have a paper under review that is sort of looking at different simplified approaches to figuring this out, but it's a key barrier to lung cancer screening.
Cool. Okay, that's what I thought it meant, which
Yeah.
to me got me thinking so maybe these guidelines are not really super, I mean, they make a ton of sense for the clinician investigators and epidemiologists, but maybe they don't really work at all in the real world, which then led me to my unfair question, which is the
Excellent.
simplest guideline of all proposed by your friend Zeke Emanuel, no screening and no treatment after 75. What do you think?
Oh, man. So, thanks a lot, Zeke. Yeah, and that he wouldn't, for cervical, you shouldn't be screened after 75, after 65, if you have 10 years plus of screening history. So I'll take the easy answer there. I think that discontinuing screening, first of all, there's this life years approach is a better way, more effective identifying people that should continue. There's racial inequities built into it, right? Because we have lower mortality in Black adults. So then when you put that in the model, it looks like they're not going to survive long, then they shouldn't be screened. And then therefore you bake in these inequities from the start. So the other thing that's really tricky about it is that, and I have a quote that I didn't present, one of the patients they were over 65 said, I get the evidence, but for me to say I need to stop screening means that the likelihood that I'm going to die from something else is greater, which means I have to face more mortality, which I know a lot of you do, great work. So there's there's increasing work thinking about how you use life years expected to cut off screening guidelines, but think about how hard that would be to implement. So I'm not going to say whether or not I agree with or disagree with Zeke, but that because I value my career, but I do, I think for most people it's true. It's about net benefit. Population approaches, net benefit. So if the risks are greater than the net benefit.
Kate, thank you so much for a fascinating talk. You presented a stunning amount of research, which is just incredible to behold. And I feel like I could ask you questions about any of them, but I wonder if you could actually just tell us about if any one of these projects, if you think about it and you just love it, you just love the science, or you love what you're able to produce. Can you just tell us about some aspect of the research that you just fell in love with?
Yeah. So to be fair, I probably love it all for different ways. The de-implementation, the complexities of it. The trial itself is going to be easy once we get it stood up. When the standing it up, the clinical buy-in, making sure we're identifying it is complex and tricky and political. Lung cancer screening, we have an opportunity to make a huge impact and sort of shift the rates, the narrative. In addition to getting people tobacco cessation support. So this overall, of course, that's the hugest way you can reduce it. But I think the one that and maybe this is back to my anthropological roots, my global work is a passion. It's also a passion because of impact. It's a passion because of complexities as well. So I was in Botswana a couple of months ago, and a lot of the work that we did was meeting with the Ministry of Health and a lot of sort of the cultural context. But it's also thinking a little bit outside of the box. I met with the pathology lab, and we're going to implement the actual strategies there. So how can we sort of use that, thinking about working within the constraints in other contexts that gets me excited.
So you talked for multiple of the studies talking about these pragmatic, smart design trials, which are just seems, speaking of complexity, just much